Okay, so thank you everyone for coming today. And we have as our speaker today, sponsored by the CTSI and our Cancer Center, Dr. Fola May. And she is going to talk about some of her work, particularly today on dismantling inequities in colorectal cancer screening and outcomes. Some of you know Dr. May very well and her accomplishments, but many of you may not. And even if you do know her, you may not really know how accomplished she is. So I'm going to tell you a little bit about her background. Dr. May is an associate professor in the Department of Medicine here at UCLA in the Division of Digestive Diseases. She's a gastroenterologist by training. And in the Division of Digestive Diseases, she is the Director of Quality Improvement in Gastroenterology. She's also the Associate Director of the UCLA Kaiser Permanente Center for Health Equity. She has been doing equity work her entire career. She, in addition, is a staff physician at the Veterans Administration, so she has many, many hats. She is very highly trained in a lot of different areas, which is what allows her to do the kind of work she does, which is interdisciplinary and transdisciplinary. She has a bachelor's degree in molecular, cellular, and developmental biology from Yale. She has a master's of epidemiology from the University of Cambridge in the United Kingdom. Her medical degree is from Harvard. She did her specialty training in GI at UCLA. And then on top of everything else, she did a PhD in health policy and management in the Fielding School of Public Health. So you can see how she is a really well-rounded researcher. So just very broadly, she engages in health services research and quality improvement at the population level, not so much one-on-one with patients, but improving outcomes for the population, both within the health system and outside as a whole. And she has done many, many studies trying to understand and address the influence of patient, provider, and system factors on many, many chronic diseases, including obesity, colorectal cancer, chronic liver disease, hepatocellular carcinoma, and so on. In the very short time since she graduated with her PhD and her training, she has received numerous local and national awards, not just for her research. What distinguishes her is also receiving recognition for community engagement and her advocacy. Everyone can't do that, and she does that really well. And she's received a lot of funding for her work from organizations such as the National Institutes of Health, American Cancer Society, Stand Up to Cancer, and so on. And she is really highly sought after for media appearances because how well she is able to articulate some of the issues that our society faces in terms of health and so on. Special focus on colorectal cancer. So welcome, Dr. May.
Thank you, Dr. Bastani, for that very warm and lovely introduction. It's lovely to see everyone today. Can you hear me okay? Okay. Thank you for coming. I'm really excited to go through this conversation, and I'm hopeful that at the end we'll have some time for questions. So if you do have those, jot them down or remember them so we can do that at the end. Quickly, I'd like to provide my disclosures. And I know that we just got a bit of an overview about what I do, but I do like to start with just generally orienting the audience to who I am and what I do. I am a gastroenterologist by training, but I spend actually about almost 90% of my time conducting research and quality improvement here at UCLA and in the VA. I've listed some of the research areas that we engage in the team, and I've also listed some of the quality improvement areas that we engage in with the health system. So it's really pairing the health services research with the quality improvement that embodies this work within the May Lab. Today, however, we're going to talk about one specific diagnosis, which is colorectal cancer. I'll talk about national trends in colorectal cancer, including disparities in early age onset disease. I'll talk about the current state of screening, screening disparities, and I'll end with a few topics that I think are very important as we discuss future directions. So every year in January or February, the American Cancer Society releases a report about the nation's state on cancer. And in 2024 was the first time the American Cancer Society announced that the US expects more than 2 million new cancer cases. They highlighted in this report that of all cancer deaths in people under 50, colorectal would be the #1 cause for men and #2 for women. And they also noted that despite the technologies we have in screening, there were 4 screenable cancers on the rise, including colorectal cancer in young adults. Colorectal cancer is currently the #3 cause of cancer of men and women in the United States. In men, it follows prostate and lung cancer. In women, it follows breast and lung cancer. However, when we look at mortality from disease, it rises to #2 on the list. And that's because when you add together the deaths in men and women from colorectal cancer, it actually goes above the number of deaths that we see in the sex-specific cancers. Many people like to call colorectal cancer and colorectal cancer screening a success story. And that is because since the mid-1980s, we have had a decline in both the incidence and mortality of disease, as shown here in this figure. And that's notable. You can see that both men and women overall, in incidence and mortality, we've had downward trends. We attribute these trends to the uptake of screening, which was introduced in the late 1980s, some improvement in treatment, and also a reduction in some critical risk factors, for example, tobacco use. This study, which was actually performed by renowned epidemiologist Ann Zauber, actually tried to quantify the different factors that are related to colorectal cancer mortality and their trends over time. The black line in this figure represents colorectal cancer mortality in the United States, and the different bars or different risk factors are contributors to high burden of colorectal cancer in this country. As you can see, the orange bar in the figure is the additional contribution of screening. So as you can see, relative to the other reasons that we have improvements in colorectal cancer mortality, screening has probably the largest contribution. I called colorectal cancer a success story, but there are 2 buts to this success story. The first is that we have persistent challenges with disparities. Colorectal cancer incidence is currently highest in American Indian Alaska Natives in the United States, followed by non-Hispanic Black individuals, followed by white individuals who are non-Hispanic, followed by Latino Hispanic individuals, followed by Asian American Pacific Islanders. And I will note that even though the rates are lowest relatively in Asian American Pacific Islanders, even within that group, it is the #2 cause of cancer mortality. When we look at mortality from colorectal cancer, we actually see a similar trend, with the highest rates of mortality in Black and Native Americans, followed by non-Hispanic white individuals, Latino individuals, and Asian individuals. We care about the stage at the time of cancer diagnosis because stage predicts likelihood of survival. I always like to tell my patients that if we can diagnose you with stage 1 colorectal cancer, your survival is over 90%. But if we cannot diagnose you until stage 4, your survival drops to 13%. And that is why we're very interested in trends over time, especially by race and ethnicity and stage. And what I'm showing here in this figure is when we look at distant stage disease, so stage 4 disease, which is less likely to be cured, we have the highest rates of individuals presenting with late stage disease and non-Hispanic Black individuals in the United States. So a significant disparities there. Following this trend, survival at 5 years is going to be lowest in Black individuals across the different stages. The other caveat to the success story is early age onset disease. When I was taught about colorectal cancer as a medical intern, I was told that this was a disease that affects people in their 60s and 70s. When I'm teaching medical students today, that is not at all what I say. I say it is a disease that you need to think about when you're evaluating a 40 or 50-year-old. And that is because of these trends. I'm going to start at the far side of the slide, where we're looking at individuals over the age of 65. And you can see pretty obviously here on this map that the incidence in this group has decreased over time, although there are some individuals who are worried of a plateauing effect in recent years. When we look at the middle figure, we're looking at individuals between the ages of 50 and 64, where there's clear plateauing. And the concerning trend is in individuals who are younger than that, age 0 to 49, on this side of the slide, where we have increasing incidence over time. Now, there is a difference in the y-axes on these graphs, which I will admit to. So this increase is not proportional to the decrease that you're seeing in the group over 65. Nonetheless, this is about a trend that we started noticing about 10 years ago and is driving a lot of the public health in this area. We see the same trends with mortality, with a decreasing or plateauing effect in middle to older individuals and an increasing effect in individuals under the age of 50, higher deaths from colorectal cancer in this group in the last several years. We call this the birth cohort effect of early onset colorectal cancer. A birth cohort effect is the concept that there is variation in a group of people's experiences or health outcomes that is based on their year of birth. And in the next couple of figures I'm going to be showing you, we're looking at the incident rate ratio for colorectal cancer for each birth cohort of individuals compared to the birth cohort that was born between the years of 1955 to 1959, which is when we see the increase in colorectal cancer. So Ronald Reagan, for example, was born in 1911. His birth cohort was experiencing decreasing rates of colorectal cancer over his when he was born. Compare that to Audrey Hepburn, who was born in 1929 and who was also diagnosed with colorectal cancer. During her birth cohort, we actually see less impressive of a decline in the incidence of colorectal cancer. Christy Alley was diagnosed with colorectal cancer as well. She was born in 1951 and died, unfortunately, to this disease last year. When you look at her birth cohort, incidence at that time was flat. And look at what we are experiencing now. Very recently, we saw the death of Chadwick Boseman, who was born in 1976. He was born in a birth cohort where we see a clear increase in the rates of colorectal cancer. So as you can see in this figure, individuals who are born in later generations or more recent generations have significantly higher risk of developing colorectal cancer compared to earlier generations. A group of colleagues and I used SEER data to look at this problem to see if we could quantify the age shift from 1992 to 2019. And what we found, first in looking at individuals who are 40 to 49, that group represented about 5% of colorectal cancer cases in 1992. In 2019, which was the most recent SEER data at the time, they represented 9% of the cohort. We looked at a group of individuals who were slightly older, age 50 to 59. And as you can see, that proportion, age 50 to 59, increased from 12% to 21% over the same time period. In fact, there's been a 51% increase in incidence in individuals aged 20 to 49 since the 1990s. And a projection that was recently published in JAMA Network Open said that by the year 2030, colorectal cancer will be the #1 cause of death in individuals who present with cancer who are between the ages of 20 and 49. So this is what prompted new guidelines. And in 2021, the United States Preventive Service Task Force published new recommendations stating that instead of starting at age 50, we should start screening for colorectal cancer at age 45. And we're a few years into that guideline now. There are very unique opportunities that we have in colorectal cancer screening. When I'm doing a colonoscopy, this is what the normal colon looks like. It's pink, it's shiny, I can see vasculature, but no lumps or bumps. 50% of people will develop a polyp in their lifetime. A polyp looks like a pimple on the lining of the colon. To the naked eye, however, you cannot tell which polyps have the potential to become cancer. Unfortunately, over what we think is an 8 to 10-year period, or maybe even longer, polyps can progress into colorectal cancers. The benefit of colorectal cancer screening is that we can prevent this progression altogether. We can prevent an individual from hearing the words, "you have cancer," by removing their polyp before the polyp has the opportunity to become a cancer. That is the prevention benefit of screening. In addition, screening also works by early detecting, finding the cancers early enough that they're curable. Despite the strong evidence for screening, despite the fact that we have guidelines, screening is underutilized in the United States. We, in fact, have randomized controlled data that supports that when we use screening modalities, specifically guaiac and flexible sigmoidoscopy, which were our two earliest screening modalities, we have a decline in both incidence and mortality from disease. The two most common modalities today are called FIT, which is the fecal immunochemical test, and colonoscopy. These are better versions of the FOBT and the flexible sigmoidoscopy. They haven't been shown in randomized trials to support decreasing incidence and mortality. They largely are supported by observational data and assumed benefit at a population level because of the prior research that's been done and their predecessors. I think that this data actually is some of the most convincing, and I'll describe this figure to you here. First, we have the blue bars, which represent use of colonoscopy in the United States over time, which you can see is increasing from the year 2000 onward. The red line represents the incidence of colorectal cancer. And this very simple figure from this manuscript really demonstrates that as we used more colonoscopy in this country, we made fewer diagnoses of colorectal cancer. Right now, there are actually 6 different strategies that you can use to screen your patients for colorectal cancer. And these will vary on test performance, how invasive they are, whether or not you have dietary restrictions. Some tests you only have to do every 1 year, others you have to do every 10 years. So these are conversations that physicians will have with their patients about the best test for them. All the tests that do not involve the colonoscopy, which again is that visual examination of the colon that I just showed you, are non-colonoscopic screening tests, which we consider 2-step screening processes or strategies. So if you have an abnormal FOBT or FIT, which are stool-based studies, if you have an abnormal Cologuard, which is a stool-based study, or abnormal CT scan of the colon, you actually are required to have a second step, which is a colonoscopy to remove or to look for and remove any polyps or cancers. And you're not really considered screened unless you've had this second step. We have currently seen a lot of variation in screening participation despite all of this evidence. There's a lot of information on this slide. I'm going to try and point you where I want you to look. First, overall, the screening rate in the United States, using these data sources, which is mostly based on EHR as opposed to self-report, is about 59%. So 59% of individuals are screened for colorectal cancer. Historically, there was a big gap between Black and white individuals with screening rates, and that gap is actually closed over time, likely due to many public health efforts. Where we're focusing a lot of our public health efforts now, however, are in groups where we still see disparities. So that includes American Indian, Alaska Native, Asian populations, and Latino Hispanic populations. In addition, we see very low screening rates in individuals who are born outside of the United States and individuals who are underinsured or uninsured. And that's where a lot of our interventions lie today. We think that these disparities are caused by many factors, many of which are adverse social determinants of health. And I know that we're all very familiar with this concept now, that it is where we are born, where we live, where we work, where we play, that often predicts our health outcomes. These are factors that aren't necessarily related to our health, that have huge implications to our health. So how close to a freeway were you born? Or were you born in a neighborhood where there's safe spaces to be outside and physically active? And we know these factors also impact whether an individual engages in preventive health, including colorectal cancer screening. I found this study very interesting from the Kaiser Family Foundation, where they looked at the number of adverse social determinants of health among individuals of color in the United States. So the bars here represent the number of adverse social determinants of health. The orange is adverse, the blue is better social determinant, and the gray are areas where there's limited data. And we're looking at each racial ethnic group. So they found that on average, Black individuals in the United States have 16 worse social determinants compared to white individuals. Same for Hispanic populations. In Asian individuals, you see 7 worse social determinants of health, and you see 10 in American Indian and Native Hawaiian groups. So again, a really interesting way to quantify differences in social determinants by race and ethnicity in the United States. We tend to think of these social determinants as causing more directly related barriers to screening and medically underserved populations. And I'm going to populate this whole slide here. Now, I could spend 45 minutes on this slide alone because there are incredible pioneers who've done research in this area for a long time, understanding how we got to disparities. I will not do that. I will highlight, however, that there are patient, provider, health system, and policy level factors. And it's the combination of all of these barriers that are leading to disparities in screening utilization. Once we have information that disparities exist and we have information about what's causing the disparities, we can talk about strategies to increase health equity. And many times health equity is a focus in large academic health centers like the one that we are at today. But one of the things that I've been very privileged to obtain training in the last several years working in the Center of Health Equity as Dr. Bastani's mentor is the power of mentee, is the power of doing health equity research paired in communities. We do a lot of work that is paired with federally qualified health centers. I'll explain what those are briefly for individuals who are not familiar with this concept of health care. These are primary care health centers that are funded by the US government to provide primary care services. They do receive funding, but they still remain resource limited to meet their clinical demands. And they also do not contain specialty services. So it's very rare that you'll see a gastroenterologist or an oncologist or an infectious disease specialist in an FQHC. You usually will have to be referred out of that setting to a specialty care setting or a place like UCLA to see specialty care. Nationally, federally qualified health centers are tasked with screening underinsured and low-income individuals in the United States for colorectal cancer screening, but their screening rates have been low. This graph actually right here quantifies their screening rates. This is data from the Uniform Data System, which our group uses a lot to perform analyses on screening utilization in these settings. This is looking at the percentage of patients 50 to 75 with up-to-date colorectal cancer screening, and the yellow bars are the screening rate for each year. And as you can see, in federally qualified health centers, the screening rate is always lower than the national screening rate. Also, we have data that in federally qualified health centers, that completion of the second step, which is that colonoscopy after an abnormal stool-based screening, is also very low. It's as low as 18% in some studies. So a lot of the partnered work we do is one, to aim to increase these screening rates, and two, aiming to address this lack of abnormal follow-up. This is actually a study that was done by a medical student in our group very recently, where he showed that overall performance in screening is low in federally qualified health centers. But in addition, federally qualified health centers took a hit from COVID that we have still not recovered from. This is the annual mean colorectal cancer screening rate in federally qualified health centers overall throughout the nation. We're looking at the United States combined is the blue line, California is the orange line, and Los Angeles County is the gray line. He was able to show that when you looked at screening in 2020, FQHCs had not recovered, and particularly FQHCs that served majority Latino and majority Black populations were suffering from lower than 2020 screening rates post-pandemic. So how do we address these problems? We address these problems using implementation science. And the evolution of implementation science is that first we determine the existence or the extent of the disparity. Then we can identify, as we've discussed, the mechanism and barriers. After that, we work towards identifying evidence-based solutions that we can disseminate and scale. And we do that on multiple levels. We do that keeping in mind individuals, communities, providers, healthcare systems, and policy change. The body of literature has given us some tips as to what's effective in this space. And we know that interventions that target multiple levels, which we call multi-level, that have multiple components, that are culturally tailored, and that are developed with stakeholders in the room with us are most likely to be effective. Another busy slide here, but again, emphasizing the body of work of literature that we have in this space. These are effective interventions to improve screening and medically underserved populations. And again, I like to look at them at these levels as patient, community, provider, health system, and policy-focused components are interventions. And often we are combining components from the different levels together to make one multi-component intervention. At the Kaiser Permanente Center for Health Equity at UCLA, we actually engage in community academic partnerships to do this work. We specifically collaborate with federally qualified health centers, where we can then develop, implement, and evaluate our multi-level interventions. And these multi-level interventions usually involve components that affect how the health system works, our workflows, providers and staff in the health systems, and also patient-focused strategies. I'll give an example of a partnership that we are currently still engaged in with Northeast Valley Healthcare Corporation. This is a large FQHC. It's one of the largest actually in Los Angeles County. And all of the sites, even though there are 15, are connected through the same EHR. This is a collaboration that has been going on for many years with Dr. Bastani and her team. And I had the privilege of being able to start working with this group as a graduate student about now 8 years ago, which is crazy to say. This FQHC serves mostly low-income, underserved individuals. It is 84% Latino with a 23% uninsured rate at the time that we did this work. And they also focus their colorectal cancer screening using FIT, which again is one of these stool-based screening tests. When we started this work, only about 51% of their population was screened, and only about 20% of the population was getting a colonoscopy if their screening was abnormal. This is an example of what I think is academic community partnership at its best, in that we were able to address the full colorectal cancer screening continuum in this work. The first grant that I'll highlight in the blue here is a grant which is early work where a multi-level intervention was funded to improve screening. So taking care of the fundamental problem of low screening rates at Northeast Valley. The second set of projects is about repeat screening, recognizing that when you have a FIT test for colorectal cancer screening, you need to get that test every year. So there also needs to be measures in place to make sure that you re-engage those patients, that they do the test every year to have maximum test performance. And that was some work that Narissa Nanzi, a grad student in our group, was engaged with over the course of 3 years. And then what became my passion project in the Northeast Valley was to look at their abnormal FIT follow-up. This is one of the first areas that I was funded in, looking at gaps in care that prevent patients with abnormal screening from getting the colonoscopy from a gastroenterologist like me that's necessary to complete the screening process. And we were very lucky to receive funding from NIH, from the Cancer Center as well, to do some preliminary work to understand why patients at Northeast Valley weren't getting the colonoscopy follow-up. And then Dr. Glenn and I, who are in the audience, were able to write an R1 proposing a multi-level intervention randomized control trial to actually impose an intervention in the clinic and in the gastroenterology practices with which they partner to help facilitate patients getting referred to gastroenterology and completing the colonoscopy. And we're really excited that we restarted this work in September, and we're now actively working with the clinic to figure out how we can implement this proposal. We have expanded this concept of academic community partnerships now nationwide as well. I'm going to spend the next few slides telling you about another project that is very similar in nature. It partners with federally qualified health centers to improve colorectal cancer screening rate and follow-up after abnormal screening. But it allowed us to work with partners in Boston and also in South Dakota. You ask, why South Dakota? South Dakota, because we thought it was very important when we wrote this grant for Stand Up to Cancer that we included all groups that were suffering disproportionately from colorectal cancer. And as I mentioned earlier, American Indians have some of the highest rates of incidence and mortality from this disease. So in partnership with our collaborators at MGH, at Providence, and in the Great Plains Tribal Nations, we developed a proposal for a plan that was funded by Stand Up to Cancer to address colorectal cancer inequities. This program also came with donated screening kits. And these kits were actually donated by a company called Exact Sciences, which makes a test called Cologuard, which is a specific type of stool-based screening test that tests the stool for blood that might be a sign of cancer and also DNA that might be a sign of cancer. So in this study, we have two competing strategies. A group of clinics, we're going to get the traditional FIT test, which is the test that most FQHCs have been using for years in the United States. There's a company that sends you a box of tests. And as the FQHC, it's your responsibility to figure out how to get those tests in your patient's hands and how to get the patients to complete the tests. It comes with no navigation. Cologuard, on the other hand, is a little bit different. Exact Sciences actually mails the test directly to the patient, and they pester the patient until the patient completes the test. So they send text messages, they do telephone calls, they send emails until the patients actually complete the test. Now, Cologuard has been used in affluent settings and well-insured populations for a while, but they had not been tried in federally qualified health centers. So we were very interested in this project to see how they would be received and if it would be more effective in screening than the low rates that we've been seeing with FIT. So again, the study aimed to, number one, establish these academic community partnerships in the 3 US regions, and then also, number two, implement and evaluate a program to increase screening and follow-up. We hypothesized that the screening would be higher in the FIT DNA, which is the Cologuard arm, because of the additional efforts that Exact Sciences does towards patients. We did think, however, that the colonoscopy follow-up rates would be similar in both arms because for the abnormal patients, they received the same intervention. So I can provide actually just some preliminary results from this study because we are still looking towards our final analyses. But we ended up having 4 clinics in Boston, 4 in Los Angeles, and 2 in South Dakota. At the time of these data, we actually did not have any South Dakota data. It took us a little bit of time to get well affiliated and associated with the tribal nation there. We also had to get approval from tribal leaders to engage in that patient population. So that part of the study lags. But the good news is we did get it off. It's just that we're going to be getting those data about 30 days later. So the study protocol was that regardless of the arm of the study you were in, you first received an invitation. And patients were given the option to actually opt out of the intervention with this study intervention or invitation that was mailed to them. Then it was different by study arm. For patients who were in the mailed FIT arm, they were mailed FIT instructions, the infographic instructions that are here in the middle of the slide. For patients who were in the Cologuard arm, the Cologuard or Exact Sciences mailed them the Cologuard FIT kit or the Cologuard screening kit. And then the reminders also varied by study arm. So in patients who were in the FIT arm, we knew we had to engage them in some way because the Cologuard arm was getting such heavy engagement from the company. So we actually developed a text messaging program to help remind those patients to complete their FIT kit. And we compared that to the Exact Sciences patient navigation program that I described. For all patients with an abnormal result, regardless of the study arm, they receive patient navigation from our study coordinators. This is up to 3 telephone calls to navigate them to colonoscopy completion. Again, these are just preliminary results. These are results for about 5,000 patients in the study. And at 60 days, we actually were already seeing higher uptake in the Cologuard or the FIT DNA arm than in the FIT arm at 23% versus 19%, which is a significant difference. Interestingly, we also saw that screening participation was higher in Boston than in Los Angeles. And this is something that's been shown in the literature before. We are now digging into factors of the patient populations, the FQHCs that might explain these differences. But Boston, with its universal healthcare, tends to perform very high, and even in their FQHC settings for preventive services. The other, I think, really interesting and beneficial aspect of this study that was funded by Stand Up to Cancer was that we were able to use several months actually to develop resources. We created videos in English and in Spanish about how to complete a FIT kit. We have written materials and infographics. We plan to use all of these materials in future studies and FQHCs that have not yet seen this intervention. Okay, I have just a few more slides before I wrap up and before we head into Q&A. There are a few areas of future directions that I just thought it was important to mention today because there's so much happening in the colorectal cancer space. The first thing that I will mention is emerging non-invasive screening tests. So many of you might have heard of the concept of liquid biopsy or a blood test for screening for colorectal cancer. This is one of the emerging tests. We have late phase tests. These are tests where all the studies have been done and they're almost ready for practice. And then we have very early phase tests. These are tests that are still kind of in the lab phase, beginning exploratory studies. These are examples of some of those emerging tests. I've highlighted the 3 that you may have heard about. The stool DNA FIT 2.0, that actually is what we call Cologuard 2.0. The company is actually coming up with a souped up version of its assay in the next year that performs better than the current version. We also have cell-free DNA, which is the liquid biopsy. This is the concept that you can go get a blood test from a peripheral vein, and that can test you for colorectal cancer. And then we have MCED, which is multi-cancer early detection. This is the idea that that blood test could actually screen you for up to 60 cancers in one go. These are things that are, I think, going to change significantly how we look at cancer screening and cancer prevention. Only one of the liquid biopsy tests is currently FDA approved, but there are 6 that are currently under evaluation. The one that is approved is from Grail. It's from Guardant Health. And these are the data that they presented in New England Journal of Medicine this year. I want to point out one really important thing about these tests. It's phenomenal, the concept that you could get a blood test and screen for any cancer, especially colorectal cancer, where the screening rates are low and people are dying unnecessarily. But these tests do perform differently than the tests that we currently use. The sensitivity, our ability to find colorectal cancer for these tests is only 83%. That's compared to 95% for colonoscopy and 93% for Cologuard. Most concerningly is the sensitivity for advanced precancerous lesions. Those are those polyps that I showed you at the very beginning of the presentation. This test will only find 13% of them, compared to a colonoscopy that will find 95% of them, or a Cologuard test that will find 43% of them. So for those of us who are really engaged in this space, we're excited that there's new technology and options for patients, but we're concerned that we're losing the prevention benefit of screening if we all switch to blood-based screening tests. So that's one thing I wanted to bring up, and I think that the panacea of information is ahead of us, and there's going to be a lot on liquid biopsy in the next 5 years, especially as more of these tests become approved. I also want to emphasize today a lot of the policy efforts that we're doing. We're doing a lot of policy efforts in the advocacy space to make sure that there is awareness about liquid biopsy, as we just discussed. And we're also doing a lot of policy towards bettering our current screening access and follow-up after abnormal screening. I had the honor in 2023 of attending the White House for a Biden Cancer Moonshot Forum, in which the Moonshot asked us to come and present on why people are dying unnecessarily from colorectal cancer. And at the end of that meeting, they asked us to write a report on what could be done nationally to improve colorectal cancer outcomes. That report is called the Colorectal Cancer Care Initiative Cancer Care Report, and it was actually released today, ironically, given the date of this talk. You can Google CRCCI Cancer Care Report, or I can give you the information about this report. This is a multi-page document that outlines how, as a nation, we can improve colorectal cancer screening rates, improve follow-up after abnormal screening, and also improve time to diagnosis and time to treatment, which our oncology colleagues stepped in and helped us with that part of the document. This was led by an organization called Fight Colorectal Cancer and the American Cancer Society, with partnership from the major GI societies, which are logoed here. The other policy effort that we are actively engaging in right now, and that I'm so excited about, is that NCQA reached out because they would like to develop a HEDIS measure, which is a health plan measure for colonoscopy after abnormal screening. As I've mentioned, these rates are very low. We fundamentally believe that you're not going to have improvement in this performance unless there's a measure. Unless health systems are measuring it, they can't improve on it. So we're very excited that NCQA is interested in meeting with us and talking about a measure. It's going to take a couple of years. I was very shocked to hear the timeline that we had our first meeting yesterday, and it won't be until 2028 or 9 that this test at the earliest would be available, that this measure would be available. But that's how these policy efforts work. Nonetheless, I truly believe that if we have a measure for abnormal follow-up, that will allow us to study it better and then also come up with more interventions to address the problem. And the third point that I want to make sure that we all leave aware of is the changing racial ethnic profile of the United States and why that's important. When we look at the US population in 1980, 80% of individuals were white. When you look at the US population in 2020, that has dropped to 58%. While we've had an increase in our Latino population, our Asian American population, and a small increase in our Black population. It's about stable, I would say. Because we have this changing racial ethnic profile in the United States, and because we know screening utilization is lowest in non-white individuals, it's especially important that we engage in this health equity work if we truly want national improvement in screening and colorectal cancer outcomes. So it's data like these that we use in a lot of our policy efforts to impress the importance of having tailored interventions in multi-ethnic populations and funding for health equity work to make sure that screening tests get into the hands of everyone, not just majority groups. So I'll stop here, and hopefully I've left plenty of time for questions. In summary, I hope that everyone will leave understanding and appreciating that colorectal cancer is common but largely preventable in the United States. There have been many recent changes in the epidemiology of disease. Increasing rates in young adults is one of the most predominant. There are other epidemiologic changes that I didn't discuss today, but this is something that we're actively studying and trying to understand, especially the environmental risk factors that might be leading to these changes. Screening should begin at age 45 for all average risk adults. That's a change in 2021. So please remind your friends, family members, colleagues that they should be screening if they're 45, and even earlier than that if they've had a family history or have diseases that put them at high risk. I've emphasized that despite improvements in outcomes in the past 3 decades, screening utilization remains low and these disparities persist. And we really think it's the disparities in screening utilization that contribute to the inequities in outcomes and why we need to have these tailored targeted interventions. And then lastly, as we discussed, there are several new screening modalities that are entering practice, and we'll have to think about the intended and unintended consequences of these tests as our patients begin to use them. I'd like to thank you for your attention and your time. I've highlighted here our many partners and our funding support. And I've also provided a link to our lab page in case you'd like to learn more about our research. Thank you very much.
I just want to say thank you to Dr. May for that wonderful overview of colorectal cancer screening. I know we have questions both from the audience and possibly also online. Go ahead.
Regarding screening, though it's an old test, barium enema, are they still using barium enema, or could it be accompanied by the colonoscopy?
Okay.
Thank you very much for that question. Nice to see you. I believe that the last guideline that included barium enema Oh, I need to be near the microphone. Can you hear me if I'm over here? Okay. So barium enema is a procedure in which we inject a contrast material into the rectum and then take a picture externally of the body to look for abnormalities in the lining. That is a test that we used to use quite frequently to screen for colorectal cancer, but it kind of became out of favor in around 2017, 18, when at that point it became written out of the guidelines. So right now it's actually not a recommended modality for colorectal cancer screening. Does that answer your question? Okay. Do you have another one? I can see you have it.
Concerning the blood test, how accurate they are for colon cancer compared with the Cologuard. And by the way, yesterday I bought from Ralph a kit.
I know.
It says 98% accuracy. Is that the same Cologuard or something else?
I know.
How many types are there? How many types are there on the? This is over the counter.
Hundreds of tests. There are hundreds of stool-based tests internationally. There are about, I think someone said about somewhere in the 80, 85 that are being commercially sold in the United States. There are only about 6 or 7 that are formally recommended, but every commercial developer has created their own fit kit. You can buy them at Target. I've seen them at CVS. Some health plans have their own that they just mail to patients outside of the health system. So those kits are the same concept that it's looking for blood in the stool, but their performance is highly variable. And some of them, I would say, perform very poorly. So it's really the golden 5 or 6 that we recommend. And those are usually the ones that are provided by your health system. As for the your first part about the liquid biopsy, the blood test for colorectal cancer screening, that has a sensitivity for colorectal cancer of 83%, which is compared to 95% for colonoscopy and 93% for Cologuard. So it's not as good as finding cancers, and it's certainly bad at finding polyps. Yeah. Other question? Oh, I see Helen right here. Hi, Helen.
Can we?
I'll come back to you, sir. I think we'll have time.
Yeah.
Hi, Dr. May. Thanks so much for that wonderful talk. So you presented pretty convincing data early on in your talk about the increasing incidence of colorectal cancer in younger patients and therefore the move to change the guidelines. I'm wondering if you can talk a little bit about the research or the theories as to why the incidence of colorectal cancer is increasing in these younger patients.
Yeah.
Okay, so just, can you pause there? Because
Yeah.
there's a question here that's very similar from
Okay.
someone who's online, which is kind of what is causing colorectal
Yeah.
cancer and what might be some of the reasons leading up to your question. So it's really the same question, and maybe you want to talk about risk factors.
Absolutely. So we know the traditional risk factors for colorectal cancer are male, sex, and age. Okay. And then we know over time that mutable factors like diet, exercise, tobacco use, metabolic disease have also played a role. But when we look at early onset, so individuals under 50, it doesn't seem like those factors are explaining it. We also know that with the birth cohort effect, this has happened too fast for it to be a genetic reason. And that's why we switched to looking at possible environmental causes for this epidemic. I knew this question was going to come up, so I added the slide to the end of my deck. This is a figure we actually created for a publication that just came out, trying to impress this concept of the exposome. Okay, so if you could think of your exposome as the body of the circle of influences you've ever had on your body. Okay, if you got to draw a circle around yourself and you looked at yourself from the time you were born to now, every exposure you've had and you quantified it in that circle, that's your exposome. So we're trying to do studies now to understand how that exposome interacts with your genetics and these somatic alterations that may be leading to colorectal cancer. And we think that the key is there. It's not going to be one thing like tobacco or microwaves. There's all these theories about microwaves. Or even microplastics is like the hot topic right now, but it's probably your susceptibility to microplastics causing cancer in your genome. So that's why we can't really separate the genetics and somatic alterations from the exposome. This is an extraordinary area of research. I'm writing my first grant in this area right now. It's an impossible grant to write. It's with some partners in San Diego and Chicago. There's some clues that it is likely in how we process food or preserve food, but there are also really strong theories about microplastics and other environmental exposures that still need to be sorted out. So I call it like the $1 million question in colorectal cancer right now.
So just one vegetarian.
Yeah,
No,
so
it's not going to be one.
very similar. Can high fat diet and changes in gut microbiome drive the increase? Okay, so this has come up a lot because some of the early data said that it was obesity and microbiome. We do think the microbiome has a role because the microbiome is the environment of your gut, but we think that's a result of a further upstream environmental factor. So yes, the microbiome is implicated, diet is implicated, but it's probably more specific components of the diet that's causing this metabolic disarray, that's causing the microbiome changes. Read the paper. I'm just kidding. But we break it down on that first paper, we break it down. Is there any more on there?
Only the ones that come up.
Okay.
That's pretty much. So can you talk a little bit about kind of both these streams and how they come together? So on the one hand, you develop polyps, you develop colorectal cancer, and you want to prevent it, you want to catch it early, you want to take out the polyps. And then on the other hand, it's going even further upstream from the polyps. And how do you bring it all together in populations?
Meaning the prevention efforts?
Yes, or at least even right now, since we don't have an answer, some kind of education. We don't.
Yeah, we don't know. Yeah. And that's the question I get asked a lot. Like, what do I do? What do I eat? The most concerning consultations we have are with a young adult. I diagnosed colorectal cancer in a 43-year-old in clinic 2 weeks ago. And then his family comes in and they all say, well, what do we do to our diet? And what do we change? And, we're going to become plastic free and never use a microwave again. And unfortunately, we just can't point to directed active change that you can induce in your lifestyle to prevent this disease. For traditional onset colorectal cancer, the things that we have found to be effective is increasing fiber in the diet, reducing the amounts of red meat in the diet. And actually the biggest signal is for alcohol. So people who have moderate or excess use of alcohol, over and over in studies, it's been shown to have the higher rates of colorectal cancer and early onset colorectal cancer. So if anything, those are the things that you probably can focus on. And getting screened, that's the most important thing, right? Because even if you miss all those lifestyle changes, if you get screened at the right time, we can at least intercept what's already happening. Question over here?
I have a question. So if you adjust for socioeconomic status within the distributions of different reported races, do you still see the differences in the rates of mortality and incidences?
Yeah, that's a really good question. And it's very interesting because there's a big body of literature that has done this with mixed results. Some of the studies showing that if you control for SES, that you actually eliminate many of the racial ethnic disparities that we've seen. Other studies showing that even when you effectively control for SES, there are still persistent disparities, particularly in Black individuals. So the disparity tends to, there's an effect modification where you see a less of a disparities effect when you look at white Asian and white Latino disparities in screening and in mortality, not so much incidence. But when you look at the white Black differences, those never go away, even when you even when you control for SES. So there is something innately about race or how race is managed in healthcare that predicts the outcome of mortality.
So can you talk a little bit about kind of what people have been saying are possible reasons for why that disparity remains? So it's not only healthcare, it's adverse childhood experiences, it's chronic stress, it's all kinds of stuff.
And there are a lot of there's a lot of literature that's pointing to a lifespan of exposures that that accumulates, and the risk of not just colorectal cancer, but many cancers. So it's the adverse social determinants that begin at youth, right? Growing up in environments where it isn't a safe space, where you're living in a food desert, where you don't have access to healthy diets, potentially environmental exposures in those settings. And then in middle life, there are actually some theories as well about stress and the likelihood of getting cancer. Chronic stress. So things like stress in the workplace or stress in the family or social stressors that prevent you from focusing on your health obviously can make it less likely for you to seek health care as well. So it's the accumulation of all these factors that we think are leading to the disparate use of screening and also the disparate use of treatment, because we see the same disparities in treatment. We published a paper actually very recently in JNCI where we showed that when you look at people diagnosed at the same stage and the same age, if you were Black, you were less likely to get timely treatment. So there is definitely a difference in the access to care or the likelihood to start care or treatment as well. And unfortunately, when you have all those things accumulating, it ends up being a huge mortality difference. In the end, that's 42% higher mortality in Black individuals compared to white individuals. Did you have a follow-up question?
Yeah. I was also wondering what your perspective is on incorporating more of the genetic screening and not just for the rare genetic forms of colon cancer, but just generally cancer risk.
That's a very important question. I'd say probably about 10 years ago, there became a new guidance that anyone diagnosed with colorectal cancer should have genetic testing of the tumor. That would inform the type of cancer they have, but also familial risk that they could share with other family members. I would say there's variable uptake of that. At a place like UCLA, I think we do a good job of testing all the tumors. At other health systems, they might not have the resources to do that. So that information about genetic familial risk isn't always passed down. There are conditions that we see. There's one called FAP, familial adenomatous polyposis syndrome. This is a condition where starting at around the age of 6 or 8, you develop polyps and you develop blankets of polyps in the colon. Those patients are easy to identify because they present to a health system. There's families that carry it. We follow the whole family. But there's more benign polyposis syndromes. One is called Lynch syndrome, which causes a few polyps later in life. And a lot of times it takes us a few generations to recognize a Lynch family. And it's not until we recognize a Lynch family that we can screen them at 30 or 40 earlier that we can prevent cancers in those families. And this is why, we say family secrets kill. Because if you're not sharing in your family your history of cancer to your other family members, they unfortunately might succumb to the same disease that we might have been able to prevent if they were aware and if we screen them early. So another big push in the public health of colorectal cancer is to make sure that people know their family history, and even having medical records track that more efficiently so patients know what kind of genetic risk they have. I have some colleagues that are very focused in that area. Does that answer your question? Okay, thank you.
Any more questions? Otherwise, we can conclude. And any last comments you'd like to make?
I just want to say thank you for listening. Sorry we're a minute over, but I really enjoyed the conversation, and thank you for coming. And thank you.